everyone. More than honored to be invited speaking before you, and of course, proud to be part of this important, from a social point of view, initiative. I'll try to wrap up the current knowledge on hepatitis B and C therapy, starting with this graph, which is a community investigation done in Taiwan years ago that established clear-cut link between liver disease severity and outcome of chronic hepatitis B with the level of virus replication. Interestingly enough, antiviral therapy of hepatitis B was attempted in the early 80s using, on an empirical basis, interferon, and yet this link, long before this link between disease severity outcome and replicating virus was established, but yet this link provided the basis, set the stage for the development of international society guidelines for therapy of hepatitis B, and also boosted the development of potent antiviral agents, the so-called all-oral NUCS. Currently, a minority of the patient is still being treated using interferon. Interferon is a natural cytokine that has a moderate anti-hepatitis B activity, suppresses viral replication, has a very significant immunomodulatory activity which results in the stimulation of an NK cell and specific T cell lymphocytes which help the liver to get rid of infected liver cells, and one above all, is able to inhibit the cccDNA, which is the hepatitis B virus template, which transcribes for a number of proteins which are of strategic importance for the virus survival and its pathogenicity. Administering for 1 year time interferon subcutaneously to the patient, you might obtain in a significant number of them an attenuation of liver disease inflammation. And following the end of therapy, you might also hope to have a kind of a permanent suppression of the disease. This translating what we call a functional cure, an attenuation of liver disease of therapy. And at the rate of 1% per year, this patient may even lose HBs antigen, a proxy to a cure endpoint. In the face of this small number of patients that still are being treated with this approach, which is limited because burdened by tolerability, poor tolerability, and also limited access to the patients. Patients with advanced liver disease or with comorbidities are not fit to receive interferon. This is well known. There is another therapeutic approach which has been made available in the last 10 years, administering orally bioavailable nucleoside or nucleotide inhibitors of hepatitis B. This is a very user-friendly therapeutic approach. One pill a day results into permanent suppression of the virus with a significant attenuation of liver disease progression. However, since this treatment is devoid of immunomodulatory activity, these patients only occasionally may get rid of the infections, losing HBs antigen. These two regimens cannot be used as an alternative, but they must be selected to target the proper patient population. And there is still a number of investigations going forward that hope to find an optimal way to combine treatments, oral NUCS with interferon, as an add-on therapy or as a combo therapy to improve the outcome of therapy. Generally speaking, you cannot use these two regimens in a very alternative manner, but you have to select your own target because the natural history of hepatitis B is a very complex one. It's a dynamical evolving process which starts at the beginning with the kind of a paralysis of the immune systems which make the virus to highly replicate and the liver to be spared by significant disease. In this period, you cannot use an immunomodulatory agent like interferon. You better go with NUCS. Subsequently, for some reasons which we still ignore, the body tries to reject the virus and is attacking the infected cell, causing hepatitis, necro-inflammatory reaction. And this is the result of an immune system that is taking place actively against the virus. At this point, you might use interferon, if the liver disease which accompanies this phase is moderate, or you might use NUCS with the hope to stop replication and attenuate liver disease. The third phase of the infection may go spontaneously into an inactive carrier state where no therapy is required. However, you must be careful. You have to follow your patients with periodic assessment of the liver test in blood because some of these patients may be diseased patients in disguise, having bouts of reactivation, which might end up with cirrhosis and liver cancer over the decades. And this patient still needs to be treated with either interferon or NUC therapy. Generally speaking, interferon can provide the clinical benefit in 1 of the 3 patients that are treated, but don't forget that only 1 of the 2 patients with chronic hepatitis B are fit to receive interferon. And generally speaking, this is welcome because you use just 1 year therapy and then your patient is free of the burden of treatment. There is no significant risk of organ toxicity using these cytokines. You might achieve in some patients an attenuation of disease progression, preventing cirrhosis, maybe liver cancer, but these are soft data because there are no intention to treat analysis data that can definitely prove that this is true. What is really true is that a significant number of patients, perhaps 1% per year, will clear definitely the infections, getting rid of the HBs antigen. Unfortunately, this treatment modality is burdened by significant tolerability and limited access to the patient, which is not the case for the NUC therapy. 1 pill a day of a nucleoside analog like Entecavir or nucleotide analog like tenofovir will result in virtual the suppression of the infection in all the patients, which might lead into the stopping the early phase of replication in 50% of the patients, perhaps in 2-3 years' time, not in 1 year time I used to do with interferon in 30-40% of the cases. You might also end up with HBs antigen in a super-selected population, the E antigen positive Caucasian. Why? Because now we are convinced that there are large differences between the sets of patients that have been published so far regarding the infecting genotype, the modality of infections that have important influence on the response to therapy. This is accompanied by normalization of ALT in a vast majority of the patients. There are no major safety issues. All these outcomes make NUC a very competitive therapy compared to interferon. Interferon, of course, can be optimized in terms of treatment modality. We are perfectly aware that patients who are chronically infected by genotype B of the virus will respond better to interferon than patients infected by genotype C. And we are aware that in our geographical area in Europe, genotype A infected patients are more prone to respond to interferon than genotype D, which is the prevalent genotype infecting the Mediterranean area. And all in all, we dispose of a stopping rule whereby we can predict after 3 months of therapy in which patient is not responding to interferon and should be withdrawn from therapy. These patients are those who are not having a significant decline in the HBs antigen concentration in the first 90 days of therapy. Despite this, NUC therapy is taking over interferon therapy because it's safe, very effective, and user-friendly. And these are also the clinical outcomes related to NUC therapy. There are many studies like this, but this is a very interesting one coming from Hong Kong and tells you that pulling data from a retrospective series of patients with a natural history of untreated hepatitis B and the prospective series of patients, those patients who have had a continuous suppression of the virus had less chances of dying over the follow-up compared to patients who had an incomplete response to therapy because of imperfect therapy, comorbidities of other reasons, and those who historical controls have never been treated. And this difference between responders, poor responders, and untreated was seen in terms of an abatement on a reduction of liver-related mortality and all-cause mortality, which is the primary endpoint of any treatment for any disease, not dying of any cause. Interestingly enough, the vast majority of patients who still had some end-stage liver disease complication leading to liver-related mortality, were patients developing liver cancer. No one developed the compensation. Why liver cancer is still burdening treatment with NUC? The most important reason is that the vast majority of these patients started therapy at the stage of advanced liver fibrosis, cirrhosis. In fact, in patients with chronic hepatitis B without cirrhosis, liver cancer was not a complication of the therapy. This notwithstanding, chronic suppression of hepatitis B results in a significant reduction in the risk of developing cancer. In a 5-year period, patients treated with NUC versus patients left untreated had a significant reduction spanning from 70% to 50% of the risk of developing cancer. But this data also challenges the current paradigm of starting therapy in patients with significant liver disease. If you wish to get rid of the risk of liver cell cancer in treated patients, we should start therapy long before, at the very beginning, whenever a viremia is detected. As far as hepatitis C story, even there, treatment of hepatitis C with an antiviral agent, interferon, was attempted long before the virus had been identified by Dr. Michael Houghton in 1989. But this anticipated treatment with interferon allowed us to collate a number of studies to understand that in those patients who were able to receive interferon-based therapy, the clinical benefit in terms of reduced liver-related mortality was there. This is one of such studies done in the Caucasian world, but there are other data generated also in Asia. You see patients achieving a sustained virological response had a rate of liver-related mortality by far reduced compared to non-responders. And very interestingly, there was also a benefit in terms of reduced mortality for all causes, telling us that the virus has some ability to affect our body beyond the liver. There is, in fact, a study done in Taiwan by retrospective scrutiny of their database indicating that patients that got an SVR to interferon-based therapy were less likely to evolve into end-stage renal disease, coronary syndrome, likely as a consequence of stopping the deleterious effect of the virus on the arteries through cryoglobulins on atherosclerosis. With the arrival of all oral therapies, we might predict that the benefit of getting rid of hepatitis C should be even greater. And currently, the European Association for the Studies of the Liver endorses a number of therapeutic regimens. Many of them are based on the NUC inhibitor sofosbuvir in combination with NSA5 inhibitor. Other is a combination, is a direct NUC inhibitor devoid regimen with an inhibitor of the polymerase non-NUC plus API plus NS5, and other one is a combination of a NUC inhibitor with an NS5 from another company. Altogether, these provide a large number of treatments available covering all the infecting genotypes we see in Europe. The first extended benefit that we might expect from the availability of all oral regimen is increased access of patients to therapy. There are no more barriers typical for interferon. This is clearly demonstrated by the Germans in this real-life study. You see, crossing the barrier of the age, interferon was toxic in the age population in terms of bone marrow suppression and kidney disease. No more liver cirrhosis is no more a barrier to therapy with all oral, and the same is true for advanced liver disease, including the compensate patients. Until yesterday, well, dead men walking, unless liver transplantation was to them made available. And the real clinical benefits that we could appreciate was in the set of those patients with compensate cirrhosis, where only 20% of them could get a cure using interferon. And now this rate of cure went up to 90% using the Gilead regimen, using the Abevir regimen, using the BMS regimen, using the MSV regimen, and using also this hybrid regimen, MSD plus Gilead. Look here, in this regimen, compensate cirrhosis could be cured following 8 weeks therapy, more than 90% SVR rates. But these are registration trials. Registration trial, you know, patients are trained to be treated. Doctors are super doctors in terms of experience in terms of Hep C therapy. We will see that this data have been replicated also in real life. Where, however, the availability of an oral regimen made a real breakthrough was in the setting of liver transplantation, where we can really appreciate that this is a life-saving strategy, compared to the rest, where you have to wait years to see whether mortality rates will decline. In the setting of liver transplantation, using SOF plus RIBA, even more using SOF combined with a PI, Simipravir by Janssen, SOF plus DACLA, NS5A inhibitor, SOF plus Ledipasvir, Arvoni, a combination by 3D by AV result, and of course MSD, PI plus NS5, resulted in remarkable rates of curation pre-transplant, cirrhotic with advanced liver disease. The only exception being represented by the limited rate of cure in patients with decompensated liver disease. These are fragile populations. They can die of liver toxicity due to therapy, infections, or impairment by other organs. And this, of course, provides us with important information. We should try to treat our patients long before any clinical decompensation. The best would be, we would see, before cirrhosis develop. And this was even more so in the post-transplant recurrence hepatitis therapy. Recurrent hepatitis C was a barrier to retransplantation in patients developing end-stage liver disease. Again, dead man walking. Currently, these patients are completely rescued to life because if you treat this patient early on, you can cure completely their recurrent hepatitis C. And the few cases of failures are just related to comorbidities that have nothing to do with viral hepatitis C. Again, the compensated patients are those faring worse. And the message here is to treat recurrent hepatitis C as soon as possible. But currently, we are treating all the patients pre-transplant. We are no longer seeing recurrent hepatitis C. So this is a kind of a miracle for hepatologists. Importantly, if you have to deal with patients who are already decompensated and cannot be transplanted, this is really the risky population left to be treated, and for whom we need to improve the current therapeutic strategy. Again, you might have a significant proportion of these Child-Pugh B patients that, following virus eradication, downgrade to Child-Pugh A. And the same is true for Child-Pugh C downgrading to Child-Pugh B. So if you are in a desperate situation of end-stage decompensated liver disease, still 1 out of 2 patients who cannot be transplanted can still have an attenuation and improvement of their prognosis. Currently, we are having data on real-life therapy. What does it mean? Treating patients with currently seeing liver units. And here, the optimism that was accompanying the release of the first registration trial outcomes shrank a little bit. You see here that there are subpopulations in which the rate of cure is down to 80%. Not to enter into the detail, TE means treatment experience, those who failed previous therapy with PEG or with third-generation PI protease inhibitors. Generally speaking, patients with accompanying cirrhosis might have higher chances of failure. We don't know why. It could be also something related to the fact that in real-life practice, you might have problem of compliance, or you might have reached the so-called no-return endpoint and have accompanying comorbidities that are affect the efficacy of our treatment modality. And here is a large series in France, multi-center study, combining sofosbuvir with NS5A inhibitor developed by BMS. And generally speaking, ribavirin, which is a toxic companion of interferon and, of course, of these new molecules, might be still needed to improve the SVR rates in patients with more advanced liver diseases, those who had the previous failure to PEG-based regimen or to third-generation PI. But all in all, what remains difficult to treat subpopulations are the genotype 3 patients. Endemic in the Indian subcontinent, but also prevalent in many European countries as a consequence of its incidence in the parental risk group. And you see here that particularly in patients with cirrhosis who failed previous therapy with interferon, the rates of curation span between 60 and 80%. And given the small sample size of the study, you might predict that the confidence intervals are even larger. So this is a place, I'm finished, this is a target that needs to be improved, and currently there is work going on. Why a significant number of patients are failing to respond in real life to this treatment regimen? Because they develop resistance, particularly to the NS5A inhibitors. And some of these patients are at risk of disease progression. Likely enough, a regimen will be made soon available that is able to kill these resistant variants of hepatitis C and provide a cure that restabilizes a good prognosis. The last slide, Mr. Chairman, is just to express my personal own opinion of what is going on currently in the area of therapy with all oral regimens for hepatitis C. Market-wise, there is a misconception that since we might dispose soon of a point-of-care test to rapidly identify a patient with hepatitis C, and companies are working hard to develop a single short-lasting regimen with a pangenotypic action, we will soon have the opportunity to counteract the hepatitis C epidemic with a single regimen of a fixed duration with the limited number of pills having pangenotypic activity. I personally disagree, because this conception might have a limitation. We still have subtypes of viral hepatitis infected patients who are resistant to currently available therapies. We are accumulating 10,000 patients who are failing to respond to soft combo therapies because of NS5A resistance variants developing in their body. We have a number of patients with decompensated liver disease that cannot be transplanted, that are still at risk of dying, and for whom there is not a cure so far available, in whom we might need to extend therapy and to repeat therapy maybe. So we need to develop, response-guided therapies algorithm to individualize therapy, not to go toward a fixed single regimen approach. Chronic kidney disease is still an orphan disease for most of the regimens we were alluding before. And then there are patients with co-medication, particularly heart drugs, that are increased risk of drug-drug interaction that might ask to stop medications against hepatitis C. And in the end, if we develop a single length duration treatment modalities in 4 to 5 years, once we get rid of all patients with cirrhosis and advanced liver disease, and we have to challenge patients with mild, moderate hepatitis C, we might not need such a strong regimen being available. And this, in fact, the use of such a single regimen might lead to a loss of cost-effectiveness ratio. Thank you for your attention.